director of point-of-care ultrasound education for the internal medicine residents at University of Minnesota. And then I have a title with the Pediatric Hospital Medicine Fellowship. I I don't actually, in truth, do a ton with them, but I do work on the teaching service over there at Masonic Children's a few times a year, and then work nights over there too, doing some POCUS stuff in kids. So here's our objectives, just kind of keeping it short. We're going to recognize normal versus abnormal ultrasound appearance of the right lower quadrant, specifically kind of pertaining to the appendix, and then describe a couple findings in intussusception, and then gather evidence for diagnosis of mesenteric adenitis, which is a diagnosis of exclusion typically in kids in a child with a non-surgical abdomen, and then recognize some findings concerning for bowel obstruction. So case one, we got a 7-year-old male, several hours, lower abdominal pain, worse with walking and urination, CBC, CRP, urinalysis, all normal, and vitals are normal. But the patient does have some lower abdominal pain with guarding on exam. The ultrasound comes out. The patient is effectively NPO because they haven't been able to tolerate anything. And what we see in the right lower quadrant is this kind of finger-like projection down here with some hyperechoic walls. We measure it, and it's close to 1 centimeter in diameter. And it looks to be attached to kind of the bottom of the cecum here in the right lower quadrant. So this would be kind of a classic finding for appendicitis. The sort of technical aspects of an appendiceal ultrasound involve looking in the right lower quadrant with the patient supine. It's tough if the patient has eaten or had something to drink recently because bowel gas often obscures your view. But I found this protocol advocated on the Radiopedia website, and it was from this article that's noted down here by Chang et al. From 2014. And they increased their sensitivity for detecting the appendix from 30% on the first supine look to this lateral posterior oblique view. It's basically just the patient laying on their left side with their right side up, and the probe is oriented sagittally. So, you're looking in the long axis of the cecum, and that's meant to look for a retrocecal appendix. So an appendix that's kind of folded up behind the cecum. If the cecum's full of gas, you're not going to see the retrocecal appendix. So it was meant to like get around that. So again, sagittal sort of orientation with the patient on their left side looking behind the cecum. And then they would do a second look with the patient supine in that right lower quadrant, trying to find the appendix. And the idea there is that maybe with them laying on their left side and you compressing several times, you've moved some of the gas out of the way, and you'll be able to find the appendix. So 30% with that first supine look, lateral posterior oblique view, they increased it from 30 to 44, and then it was around half of cases they were able to identify the appendix by the time they took that second look. Some of your anatomical landmarks are going to be the rectus abdominis. So the abdominal musculature is going to be up here in the near field, and it's often pretty well defined. You see sort of that fascial sheath around it. And then your iliac vessels also are going to be visible generally. Those are going to be medial to where your appendix is located generally. So your iliopsoas is generally deep. Your rectus and iliac vessels are typically medial. And the three things sort of form a triangle oftentimes that you can look in to try to identify the appendix. Another approach is to trace it from the cecum. So we know that the long, that large intestine, the ascending colon is going to be on the right side of the abdomen. So just kind of starting over as far right as you can go and trying to move from that sort of subcostal area down all the way to the kind of the flare of the ilium, trying to find and identify that cecum. and looking for where it ends in the blind pouch, and then kind of migrating over towards the midline. So the civets technique, this is a look at that LPO view, by the way. The civets technique is described here. It's basically just kind of you're doing like a spiral in that right lower quadrant, starting at the level of the umbilicus in a transverse view, and then going down. This 2 is sort of trying to trace the cecum, and then 3, we're trying to find if there's the appendix is sort of pointed or oriented towards midline. And then once we hit the lateral margin of the bladder, that's this 4 or 5, we're starting to go back up towards the umbilicus. And then you can change your orientation to a longitudinal one over here and try to comb this area. But it's sort of a lot of the abdominal ultrasound stuff, they advocate for a lawnmower approach. You see the lawnmower in there a lot. A lot of people are mowing their lawns, it seems. So sort of the best way we have to describe this. But you're just trying to cover all your bases and to identify relevant anatomy sort of in each area so that you can hone in on the structures of interest. So that was a lot to to say. These are the things that you're looking for in an abnormal appendix. This target sign. So when we have kind of a swollen appendix, the muscles are going to be more, or the outer layer is going to be more apparent. And generally, what you have is this kind of alternating hypo and hyperechoic circles that form this target. It might be non-compressible. So generally the intestine is compressible. And if you see cecum or small intestine, if you apply some graded abdominal pressure, you're able to squish it shut, especially if there's like fluid or food that's floating around in there. With somebody that has appendicitis, that's typically not the case. It's also very painful for you to compress directly on the structure. It doesn't come up as much in pediatric medicine, but in adult medicine, when we're looking at the gallbladder and there's a concern for cholecystitis, the sonographic Murphy's is a direct palpation of the gallbladder with the probe. And this is kind of similar. You're compressing directly on the appendix to see if that's the spot of maximal pain or it reproduces the patient's symptoms. Um, Oftentimes, if there's an appendicolith, you're going to see something that looks hyperechoic or bright within the appendix and then shadowing deep to that. So this would be, when there's like an obstructive stool ball in that appendix that's causing this. And then some of the measurements that you can just try to keep in the back of your brain are greater than 6 millimeter outer diameter. So that's from outer wall to outer wall of the appendix. That would constitute a swollen appendix and something that that would be concerning for appendicitis. And then for the wall itself, so we're talking about one wall here, it would be greater than 3 millimeters. This is a transverse view. You can kind of see that target sign, and then this is a longitudinal view. So this is a little obscured, the proximal part of the appendix, by a little bit of gas there, but you can kind of see the outline of the that finger-like projection there. And then sometimes you'll also see in a perforated appendix this free complex fluid collection. And if you put color Doppler on, you might see some increased blood flow around that area of inflammation. I think for our sake as pediatric hospitalists, maybe these are some of the use cases. Say a patient is admitted for observation and maybe they're not that sick. And so they tried to get an appendiceal ultrasound, but couldn't because there's too much gas in the way. And they didn't get a CT because, again, like maybe the labs or vitals didn't suggest something significant, but all of a sudden you have kind of an acute change on the floor. I think probably in that case, it's worth it to look at least and see if maybe some of that gas has subsided. And then admitted for a conservative management of appendicitis. So maybe surgery just wants to observe them and see if they're going to get better with antibiotics, with a plan to discharge on Augmentin or something. And then they have a sudden clinical change. That might be a situation where it's important to look. And then if you're doing outpatient or ED or international work, this might be an important exam for you to know how to do. Case two, we've got a 2-year-old male, intermittent abdominal pain. They come into the emergency department with malaise and they're dehydrated. Parents deny bloody stools. Viral testing is negative. They're admitted for IV fluids overnight, and you get paged at 2:30 about recurrence of abdominal pain. The patient's inconsolable. On exam with the ultrasound probe, you see this, what looks like, so we went from long axis to short axis. I don't know if it's going to cycle back through, so I'll just open up this slide again. It will cycle back through, it just takes a long time. Long axis, we have this kind of sandwich appearance, and then when we switch to the short axis, we've got this sort of donut looking thing. And I'll let it go one more time through there. Long axis here, kind of looks like a sandwich that's been cut. There's an old website I used to like called Scanwiches, where someone made sandwiches and then scanned them, but it was in like cross section, and that's what this reminds me of in the long axis. And then in your short axis, you've got this kind of redundant layers of intestine overlapping each other. So this is an intussusception. Here's an image of normal kind of ileocecal intestine down here. So we've got kind of the lateral border of the bladder over here comes into frame. Your psoas is going to be deep down here. And then you've got some cecum and improbable small intestine coming over here that's a little bit redundant. That ileocecal area is kind of what we're primarily interested in for intussusception. Large bowel intussusception often is going to require intervention by radiology to do like an air enema to reduce it. Small intestinal intussusception oftentimes it resolves spontaneously and doesn't generally cause the same variety of symptoms. But here we're just tracing the cecum. So again, we're starting in that right lower quadrant. You can even use the same protocol as that Civets method we talked about, where you're just kind of doing a spiral, starting at the umbilicus, working your way out laterally, then down and over, and then kind of just working in that area to try to identify that ileocecal area. And then if you don't see anything, then the next step would be to try to trace in a transverse orientation to the colon to its termination. A lot of this is going to be dependent on what the patient tolerates too. So, if you have a 2-year-old that's inconsolable, it's hard to say how much of this they're going to tolerate. So you want to focus on kind of the areas of highest yield, which is generally going to be right lower quadrant. This looks pretty blurry on my screen. I'm not sure what it looks like for you, but it's just a still of that GIF I was showing. And your normal bowel is going to be comprised of these 3 layers essentially. You have that really thin, bright serosal layer, followed by your more hypoechoic submucosal layer, and then a brighter mucosa as we go towards the center of that bowel. So our findings again for our long axis are this sandwich or pseudo kidney sign. So occasionally it's been described as looking like a kidney where a kidney ought not be, or maybe you identify the kidney and then you see what looks like another one kind of in the pelvis, and they don't have a transplant. In the transverse view, it's this kind of donut appearance where you have kind of redundant layers of intestine. It just looks like there's too many layers here. We have kind of alternating hyperechoic, hypoechoic, hyperechoic, hypoechoic, hyperechoic. So that's too many. If you're measuring in short axis, oftentimes what I saw in the literature is that a cutoff of 2 centimeters generally is what's used to separate large bowel from small bowel. So if it's less than 2 centimeters, that like outer wall to outer wall of that donut sign, that typically implicates small bowel. If it's greater than that, then that's more likely small bowel or large bowel or ileocecal. This is from a paper that's noted down here, Lubashevsky et al. From 2013. They looked at a retrospective review of positive cases of intussusception on ultrasound, and they found that the ileocolic ones, the diameter was a lot more likely to be above 2. So it's around 2.5 was their their mean with a standard deviation of about 0.4 centimeters. And in the small bowel intussusceptions, it was closer to 1.5 with a 0.4 standard deviation. Use cases for this, I think intussusception is one of those things where sometimes we don't always catch it on admission, even though the story seems to fit. And it could be because it reduced on its own. Then patient comes in for observation and they have recurrence of symptoms, and you want to be quick to catch that. If you work at a place where you can save images to the PACS, I think this could improve time to reduction on the floor. Let's say that like you get paged at again like 2:30 in the morning, you show up with a probe and are able to save images and then page radiology and say, hey, I think this patient's story is in line with intussusception. This is what I saw at the bedside. Can we like prep for an air enema for them? And then again, rural and international work. I think I repeated that in all of the use case slides because it's just obviously like a handy thing to be able to do in settings like that. Case 3, we've got a otherwise healthy 7-year-old lady with abdominal pain, nausea, and vomiting, kind of mildly elevated temp and some tachycardia, white blood cells marginally elevated, but on exam, abdomen soft, non-distended. They are, however, tender in the right lower quadrant. And on admission, the appendicitis ultrasound was negative. So this patient had come in for observation just for fluids. You review the images from the appendiceal ultrasound, and this is what you see. Um, uh, Conveniently not commented on. But what you notice are these kind of hypoechoic ellipses, these sort of ovular structures that are clustered here in a bundle. And that's a pretty typical finding for mesenteric adenitis. So again, it's going to be pretty commonly found in the right lower quadrant. You have this jumble of lymph nodes that appear there. This is a diagnosis of exclusion, and it's in a patient with a non-surgical abdomen. So important to note that lots of things are going to cause lymph nodes to swell in the abdomen, and I would only ever diagnose this in a case where I saw that cluster of lymph nodes, and I didn't have a better explanation from the rest of the workup in a patient that was relatively well appearing. This is the same protocol basically, but just on a different abdomen here, as what we looked at for our appendix protocol. We're starting near the umbilicus, moving over towards the margin of the abdomen where the cecum is, and then down, over and up, and then changing our orientation to longitudinal so that the probe marker's towards the head, and then kind of combing this area. If you put color Doppler on, you might see increased blood flow around those lymph nodes, but not within them. And I didn't order that correctly. So there's an image back here that's like behind this that just shows basically that in this paper from Sung et al. In 2024, there was a really wide variety of things that caused mesenteric adenitis, including COVID-19, pyelonephritis, different viral syndromes, and even recurrent TB. So what we're looking for, this is a normal appearing lymph node here. This is a pretty superficial one from around the inguinal area. But what we're looking for is this kind of hypoechoic, sort of bean-shaped structure. It looks like a miniature kidney. You have this like hyperechoic bright signal in here where the hilum of the lymph node is. And typically that short to long axis ratio is about 1 to 2. So if you see more than or equal to 3 enlarged clustered lymph nodes and you don't see evidence of appendicitis and there's not really a more compelling explanation, then you could potentially make diagnosis of mesenteric adenitis. There was a lot of dispute in the literature about what constitutes normal versus abnormal size, especially in the abdomen. And it looked to me like greater than a centimeter in the long axis and about a half a centimeter in the short axis was essentially relatively safe for calling it enlarged. But again, I don't think that that's like widely agreed upon. So lots of things again can cause enlarged lymph nodes in the abdomen. If you have other clinical things that are concerning, then I think that patient needs additional workup, and you can't just chalk it up to mesenteric adenitis. So for example, you have labs that are tough to explain, like a leukopenia, or the patient's had a lot of weight loss, or they've traveled from a tuberculosis or HIV endemic area. Those are reasons I would want to look into that a little bit further potentially. Um, but I think this could help to establish a diagnosis in a patient with a non-surgical abdomen who maybe comes in for obs and fluids because they haven't been eating and drinking well, and a lot of the history suggests it's a viral syndrome. Case 4, our fourth and final. Got a 5-year-old male, chronic constipation with abdominal pain, no stool for 2 days, multiple episodes of non-bloody, non-bilious emesis, and a soft but distended abdomen that's diffusely tender without peritoneal signs. And I kind of wish I had put these up front, but let's say that you see a few of these things. I think this one actually was from that case. So what we see is this dilated bowel, and it seems aperistaltic. So there's really not a lot of movement in here. What you see is a bowel that's more than 2 to 2.5 centimeters. So if we keep our eyes over here on the right side of the hash marks, this is a 0.5 centimeter little dot, and the line is a centimeter. So I have a 1 to virtually 3 centimeter dilated bowel here, and I'm not really seeing anything move through there. It kind of looks static. So that's reduced peristalsis and a widened bowel. And then occasionally what you see is this to and fro movement. So it's obstructed. The bowel is trying to peristalse. This is kind of earlier on, and stuff is pushed forward, but then it runs into that obstruction and ends up going back. So you're seeing this is like a redundant loop of bowel. Here's the dividing line between this loop that's kind of making a dog leg here, and it's going forward, and then it runs into some resistance, and then it ends up moving back through there. So that's that to and fro motion that you would see for a bowel obstruction. For protocol, generally, again, it's a lawnmower approach. This is probably not a pediatric patient, and if it is, they might have like early puberty or something like that. But essentially what we're doing is taking a transverse approach first, kind of combing the abdomen, and then a longitudinal approach. I think clinically, probably the highest yield thing would just be to, on your exam, try to find the area of most tenderness and then look at that spot with the ultrasound, especially if your patient's not going to tolerate a lot of you combing up and down on the belly. And then if you don't locate anything and there's some historical features concerning for obstruction, then I would try to take this more thorough approach. Use cases for this, I would say diagnosis of obstruction in a co-managed surgical patient. So say a patient came in for a different abdominal surgery, and then all of a sudden they're not passing gas, they haven't had a bowel movement in a day, and you're a little bit concerned that they're not able to eat and drink, and probably your surgical colleagues are going to be on top of this and ordering abdominal imaging before you ever come at them with a probe. But I think also it could aid in the early diagnosis of an obstruction in a patient with a suspected benign cause of abdominal pain and distension. And things to pay attention to there, obviously, are going to be someone with a history of abdominal surgery. So a kid that had had a surgery as a neonate for some reason, or it had like an abdominal thing removed, and now they're coming in with this nausea and vomiting. And then again, international rural work, identification of something that's going to require transfer for surgical management. These are our objectives. I hope we got there. I don't know that I spent too much time showing you images of a normal appearing right lower quadrant, but if you have access to an ultrasound machine, I think it's a good exercise to look for your own appendix. I have a hard time finding mine sometimes, so It's not an easy exam. I would say it's like a tricky thing to do, even in someone that's pretty well versed, but you can at least identify some of the landmarks. The psoas muscle, not hard to find, and then same with the iliac vessels. And if you're looking somewhere in that neighborhood, that's a pretty rough marker of where your appendix ought to be. We talked about that target sign and the sandwich or pseudo kidney sign for intussusception. And then we also talked about finding a cluster of lymph nodes in the right lower quadrant that might support the diagnosis of mesenteric adenitis in a patient with belly pain and maybe like a low grade temp, nausea, vomiting, and not really any other features that are concerning. And then we just talked about our to and fro sign, dilated bowel greater than 2.5 centimeters, and lack of peristalsis in a patient with a possible bowel obstruction. And here's a QR code if you want to dive a little bit deeper and read any of the articles that I referenced. I also took at least a couple images from the POCUS Atlas, which I don't think that I noted on here, but they have a little icon in the bottom right of all of their images. So if you're interested in some more like POCUS findings related to these diagnoses, um, I generally find that case reports from the emergency medicine literature are great, and they usually include videos, like little video clips of their exams. So that's where I would recommend looking in PubMed is POCUS, whatever the thing is you're looking for, and then case emergency. Nice. With that, I will see if you guys have any questions, and then we can kind of wrap things up.
Good job, Scott. I will say that the normal appendix is extremely hard to find. It's easy to find an abnormal appendix. The normal appendix is about 2 millimeters in size. And I typically start by finding the psoas and iliac artery, and it should run across, 60% of them run across there. So that's where I start. Also, remember with intussusception, like we talked about small bowel, large bowel, ileocecal, the treatment for small bowel to small bowel is different than the other two because the pathogenesis is typically different. In Peds, most of the time it's HSP, which the use is steroids and not air contrast. So I just wanted to make sure people understand that. You can also see an ileus instead of small bowel obstruction too. They kind of present the same. So it's all again all about taking your history.
Yeah, I feel like I've heard the reverse peristalsis as like a discriminant, to help discriminate between SBO and like pseudo obstruction or ileus. But I've seen it in both, and so it becomes really challenging. So just something to keep in mind. The other thing with obstruction with is you can see the plicae circularis, so it gives you like a keyboard sign. I can see if I can try to find some examples of that. Mm.
And then in the chat, looks like Heidi said, what is your opinion on the often mentioned, quote, too large for ultrasound claim? I'm not sure what that was in relation to, but if she's still on.
I didn't talk a
Like
lot about
body habitus.
I'm sorry. At my institution, I find a lot of my colleagues are like, well, they're adult size, they're big. You'll never see an appendix. Just go straight to CT. And that is in reference to the fact that at my institution, we don't actually do like point of care ourselves, but even ordering an ultrasound as the first step, I find that a lot of people are like, well, they're big, they'll never see it. So that's what I was wondering, whether you find that that's a concern, because I've read studies that say that that's, not actually true.
I'm going to argue against that because where the appendix is located, people are generally, unless they have a huge pannus, are pretty thin there, and you can see the appendix. You may not see a normal appendix if they're very large, but you can at least see an abnormal appendix. And so if you see you see appendicitis on ultrasound, then why go to CT? Because it's that sensitive and specific. So I wouldn't let that dissuade you.
Okay, that's what I am thinking, but I hear it so often from my colleagues that, well, we'll just go to CT. And I show them the studies and say, well, it shows that the BMI doesn't actually affect the sensitivity. But anyway, I just didn't know whether there was a anecdotal, because in my institution, we did just recently have our ultrasound techs educated, and so we've got better results. But for a long time, it just felt like nobody ever saw one. And so we always were going to CT.
Seeing is believing. And so if you start showing the naysayers and be like, look, this is what I did. It's like getting the surgeons to buy in. It's like, see, I told you.
Excellent point.
You can win people over that way.
Excellent point. Thank you.
To Duncan's point too, there's you can compress a lot of the subcutaneous tissue in that area to decrease the amount of depth that you have to use. And I didn't talk a lot about probe selection, but generally you're trying to do this with a linear array probe, one that has high resolution. So it's high frequency, but doesn't have great depth of penetration. It's sometimes in larger kids or adults, you're sort of forced to use the abdominal probe because those linear array ones, that have the high definition, only go to a depth of about 8 centimeters. So if the structure you're looking at is appreciably deeper than that, sometimes it is a little bit harder to see because you're using a lower frequency, lower resolution probe, that abdominal or curvilinear probe.
Remember, you can change frequencies on those probes. So, I mean, they're set at a low frequency, but you can generally change them to 1 or 2 frequencies higher to give you better resolution. So you still get the depth, more depth for your buck, but a little bit better resolution.
And also just a reminder in terms of when you're the less depth you go, the better the resolution. So even within one probe, if you're trying to minimize how deep you are, you'll also optimize your image that way.
Don't forget
That was
about
great, Scott.
don't forget about bladder for abdominal pain too. Because if you have an obstructed bladder, that can give a lot of abdominal pain. Oh, good image. Way to pull it. Because we've seen some kids with obstructed bladders that have presented with abdominal pain.
Here's the image that Andrea shared in the chat. So you've got the plique, like she was saying, these kind of fenestrations in the bowel, and then this is fluid that's collected in the abdomen between intestine. So you have the that like Tonga or bikini sign. Probably it's due for a more politically correct thing at this point, but I'm not sure what that would be in the moment. Now that's all I can see. So I'll stop sharing that. Cool. Thanks so much for joining, everybody. And Justin had a 1.5 liter bladder yesterday that he scanned. That's a lot. Yeah. No bueno. Not supposed to fill up that great. Right on. Well, I will pull this recording from the cloud, maybe a little bit later today or tomorrow, and then add it to our YouTube cache of videos. And thanks so much for everybody's input and expertise. Awesome. Appreciate everyone coming. And I think our next thing will be the third Thursday in March. We'll do either more like case sharing stuff, or potentially if we can get our act together in time, maybe a kind of a round table about what everybody's doing for curriculum at their respective institutions. It'd be kind of cool to hear from folks.